of the head and neck surgeons here at Methodist, and one of 7 taking care of patients with head and neck cancer and basically managing some of the difficult airways that we would see here at Methodist. So next slide, please. These are the goals and objectives that I wanted to talk about, so that giving a lecture on tracheotomies and laryngectomies, there's some key points, but it's not that long and intensive lecture to just talk about those 2 procedures. But I do think it's important it gives us the opportunity to understand a little bit of head and neck cancer and why somebody might need to have a trach or have a laryngectomy. And so I think this is a good forum to kind of review those kind of things and have that kind of discussion. Then we'll review the normal anatomy and we'll understand the differences between the tracheostomy and a laryngectomy. Next slide, please. So the first thing is understanding how we get cancer and why we get cancer, and to the point where where it grows that you would need to have an airway managed, right? And so cancers basically are they have to create their own little environment. So the first thing that they have to do is they have to escape the immune system. They have to get around our immune system. And once they do that, then they have to start creating their own environment, which they can grow in, creating their own blood supply, getting their own growth factors, which allows them to grow independent of the rest of the body. And once it's able to survive, then it continues to grow. And you can imagine in the head and neck, that's a very tight area where it's growing in, which can infringe upon the airway, if it's a laryngeal cancer directly, or if it's like a tongue cancer or a tonsil cancer, it can cause airway problems by mass effect or by bleeding into it or direct invasion as well. Next slide, please. What I like to show in this slide is just kind of talking about head and neck cancer in general. So when you look at the chart on the left, what you see this big curve that goes up, that represents all cancers. And then on the bottom, those little lines down there that don't really take a bump off, that represents head and neck cancer right there. So very small piece of the pie when it comes to cancer treatment. So we represent maybe 5% of all cancers. But it's like real estate, right? That's what we always kind of say. It's like real estate. Even though it's a small area, a small piece of property, it's a very vital area and a vital piece of property when it comes to breathing, when it comes to swallowing, when it comes to our appearance, when it comes to talking. All of this is done from the head and neck. So yes, we're a small percentage of cancers, but a very vital. Now the curve on the right actually shows that the incidence of all cancers was going down. And then over the last several years, that incidence is going back up. Next slide, please. And this kind of shows the same thing. So this is data from the SEER database. And so starting with that curve on the right, that is showing that in oral cavity and the pharynx, so these cancers are back on the rise. And mostly because of the HPV-mediated virus that's causing these cancers to be on the rise. And so that's what we're seeing. And then the curve on the left just kind of shows you some of the more common cancers that we have of the tongue and of the oral pharynx. But by far, what we see most in our clinic now is HPV-positive cancers of the tonsil and of the base of the tongue. Next slide, please. The next thing that when we talk about cancer in general, this is always how fast things have changed and technology has advanced over the last several years. Just think about it, right around World War II, more people were dying of infectious disease than they were of any other medical comorbidity. And then we got then we were able to develop antibiotics, and our treatment for the infectious disease got better. So now people are living longer, waiting to get other diseases, and then they died of cardiovascular disease. So for many years, from the 50s up until about now, more people were dying of cardiovascular disease than any other disease. And now, for the first time, cancer has surpassed cardiovascular disease. So as we got a better job of treating heart disease and diabetes and all the other problems that are associated with our cardiovascular system, we're getting people to live longer. You live longer, your immune system doesn't work as well, you have more genetic mutations, you have a higher probability of getting cancer. So now we're getting people who are living longer, we're getting people who have more cancer, and so the incidence of cancer is going up, and we're getting more people with cancer. So sadly, it's a problem that's not going away. Cancers of all subsites, and like I showed you before, of head and neck cancer is on the rise. Next slide, please. Why do we get cancer? Smoking and drinking is, basically when it comes to head and neck cancer, I always like to divide it into 4 different categories. One's a thyroid cancer, second is a skin cancer. Then our mucosal-based cancers are those that are smoking and drinking, and those that are the HPV-mediated cancers because they behave differently. And yes, of course, genetics and bad luck also play a role in it. Next paragraph, please. Or next. I feel like I'm dictating. That's my problem. I'm in clinics. I'm dictating today, so it's always next paragraph, next paragraph. So what this chart shows is, if you look at where it says 0 and 0 and that little orange box there, that's if you're a non-drinker, non-smoker, and setting your relative risk if you don't drink and you don't smoke at 0 of getting cancer, saying if you don't drink, you don't smoke, even though it's not true, but from a statistical analysis, we're going to put your relative risk at 0. And then that's, as we go along that left axis, and it says alcohol, and what we define as a heavy alcohol consumption is really about 20 drinks a week, of beer, equivalents of beer a week. So if you drink about 20 beers a week, that puts you at a higher, we say that's high alcohol intake. So if you go from a relative risk of 0 of a non-drinker, non-smoker, and if you didn't smoke and you drank about 20 equivalents of beer a day, the risk of you developing cancer is about 2 to 4 times that of the general population that were non-smoker, non-drinkers. Now, if you go along the curve to the right, or the line to the right, there again, that relative risk of 0 if you're a non-drinker, non-smoker, all the way up to a 20-pack year history of smoking plus, is what we define as heavy smoking. Your risk of developing head and neck cancer, there again, probably about 5 times that of a non-smoker, non-drinker. You combine heavy smoking with heavy drinking, you're about a 20 times risk of developing cancer. Compared to somebody who doesn't drink or doesn't smoke. So they have a very synergistic impact on one another. Next slide, please. Now compare that to the HPV virus. So this is the other mucosal-based cancer. The key to remember when we're talking about the difference of these 2 cancers is that where you see in the green on this, where it says P53 and that PRB, so that's the P53, that is a protein, and then the PRB is called the retinoblastoma. These are genes that code for proteins, the P53 and the retinoblastoma protein, that work to prevent cells, for cancer cells, from continuing to grow. So those are both, they are protective to us, protecting us from cancer cells. So in smoking and drinking, those can be mutated, meaning they just don't work correctly because they're mutated. And when there's one mutation in one gene, there's other mutations in other genes. And that's why smoking and drinking cancers are a lot worse, because they cause a lot more mutations. Whereas the HPV virus, what it does is it gets incorporated into our DNA. and then it creates these other proteins, those E6 and E7 proteins that bind to that P53 and retinoblastoma, which prevents them from working. So there's no mutation. It just prevents these things from working. So there's no other genes and proteins that are mutated. And so for the most part, HPV-mediated cancers do better than the non-HPV-mediated cancer. Then in the bottom right corner, you see that P16 going up. If you hear us talking a lot of times of something being P16 positive, that's a surrogate marker for the HPV virus. So that P16 goes up. It's a special stain that they look at, which is not the same thing as what's shown on here, but it's a special stain that they look at to kind of tell us if it's caused by the virus or not. So we don't typically directly test for the HPV virus. We're doing that surrogate marker of the P16. Next slide, please. So when we talk about cancer, we talk about it in a staging, and this is important when we talk about the airway, right? On airway management, because when we staging is the idea of staging is to provide a universal way of describing something, so that we would have an idea of the prognosis, and we would have the idea of the tumor size and the tumor volume and the tumor bulk. So when we talk about tumors, the tumor itself, that's the local disease. So if a tumor starts on the tongue, it's a tongue cancer. That's the local disease, and from there, that's what we call the T component of staging. So you get a score of 1 to 4, a T1 through a T4. The first three, so T1, T2, T3, for the most part, is based on the size of the tumor. It's also based on the depth of invasion of the tumor. And you can imagine for areas like the voice box, you could get a 3-centimeter tumor on the tongue, but if you get a 3-centimeter tumor on the voice box, that has a lot more side effects associated with it. So size is important when we talk about hypopharyngeal and laryngeal cancers, but also the number of subsites that are involved kind of help. So you could have a smaller tumor, but it's involved in multiple different subsites. That makes that laryngeal cancer a higher stage. The other part of staging then is the nodal disease. And when we talk about nodal disease, we score it based on the size of the nodes. We score it on the aspect of there are just multiple lymph nodes on one side, or there are multiple lymph nodes on both sides. Is there cancer spreading outside the lymph nodes? And so when we start talking about lymph nodes, then we're talking about regional disease. So it started from locally at the tumor and then spread to the lymph nodes, and that's a regional disease. So when we talk about curing cancer, we're talking about controlling the disease at the local and regional level. So at the lymph node level and at the primary site level. When it starts spreading to other parts of the body, that's metastatic disease, and that's not curable cancer. And that's when we would go palliative or hospice care. Go ahead, next slide, please. So the normal anatomy of the upper aerodigestive tract. So obviously it starts at the lips, ends at the esophagus from the when we talk about the GI side of things, and it starts at the lips and ends at the trachea when we're talking about the respiratory side of things. And obviously in this audience and this crowd and what we're talking about, we're going to be worried more about the respiratory side of things. So from the nose, the oral cavity, down into the larynx and into the trachea. Just in general, when it comes to head and neck cancer, and we talk about head and neck cancer treatment, anything above, forward of the anterior to the tonsils, we always say is treated with surgery. Anything behind the tonsils treated with radiation. I think you guys know that that's not necessarily a 100% true. That sometimes we radiate things that are in front of the tonsils, and sometimes we operate, especially with the use of the robot, of areas behind the tonsil. Go ahead and next slide, please. So what's the normal anatomy of the larynx? So the slide on the right side of the screen demonstrates that the voice box, and you can see what's marked with an E there. That's the epiglottis, and the epiglottis goes down into the airy epiglottic folds where it says the AE. So the arytenoid is the A, so it's the cartilage part of the larynx on the posterior aspect, and the area between the epiglottis and the arytenoids is the airy epiglottic fold. Number one shows us the glottic larynx. The arrow there is pointing to the ventricle. Number two, the two is showing us the false vocal cords, or the false vocal folds. So that's what those are showing. So the E is epiglottis, A is arytenoid, AE is the airy epiglottic fold, 2 false vocal cord, arrow is the ventricle, 1 is the glottic larynx, and the P is standing for the piriform sinus on both sides, which is part of the hypopharynx. On that picture also, you can see that the base of tongue is sitting right above the epiglottis. So, tumors of the base of tongue, how they can obstruct that airway, like sometimes by ball valving in, sometimes by direct extension into the voice box. In that any tumor of any of this area that you can see on this picture could be an airway problem, an airway emergency. On the other side, on the right side there, sorry, is the cartilaginous structure of the larynx from the external perspective. And that's very important for us when we start talking about surgical airways and surgical management of airways. So the top of the larynx is the hyoid bone. The next cartilaginous structure that we can see is the thyroid cartilage, and the third is the cricoid cartilage. Each one of those areas have membranes in between the two of the, there's the thyrohyoid membrane, and then there's the cricothyroid membrane, which are soft tissue components in between these cartilaginous structures that give the support. So anteriorly, the trachea is cartilage. Posteriorly, it's we call a membranous trachea, so it's soft tissue. The cricoid is the only cartilage that goes all the way around, so it's a complete ring, that cricoid cartilage. When you look at the thyroid cartilage, and this is important when we're talking about surgical management of the airway, the vocal cords sit within that thyroid cartilage on the lower half, lower third of, right about the lower third of that thyroid cartilage, where your vocal cords are sitting on the internal aspect of the larynx. Go ahead, next slide, please. So when we talk about establishing an airway, non-surgical management is by far the best way of doing it. And doing it in a controlled fashion is the best way of doing it. Unfortunately, though, we have patients that come to us in distress, that they let a tumor grow or something happen to them. Sometimes it's trauma, and now something is not a controlled setting. So establishing an airway is still non-surgical options first and foremost, and the technology has dramatically changed to make this a better opportunity for us. So first is intubating. Can we use the Miller blade or the Mac blade? And if you can't do that, can we do it with the glide scope? And quite honestly, the glide scope, it becomes the first line in majority of intubations now that you can see up on the floor. Operating room, it's just so much nicer to see the views through that glide scope. Also, what we do is some of our difficult airways down in the operating room is that the glide scope, the newer glide scope, has a fiber optic scope on it as well. So we can actually look at using the Mac blade with a fiber optic scope in a picture-on-picture and see both cameras at the same time. So basically, I will tell you that glide scope with the fiber optic option and the picture-in-picture has almost taken away our need to do awake tracheotomies. Early on in my career and early on in training, especially when I was in Oregon, doing my last year of fellowship. We did so many awake trachs. Almost every head and neck cancer patient received an awake trach. Very rarely do we ever do that anymore now, just because of the technology to help us establish that non-surgical airway. But then, for like the base of the tongue cancer, where you have this large mass that can ball valve down. So as you lay down, the mass might fall down and obstruct your view. Sometimes you have to do those awake, where the patient's breathing on their own, and you go in with the camera into their nose with the tube attached to it, and you gently push the tube and the camera down through their nose. Well, they're sitting up, they're awake, but they're asleep, but they're breathing on their own. And you establish an airway that way to kind of protect you from a ball valving base of tongue mass. This is always the preferred way if it can be safely done. And then we're always prepared to have to manage that with a surgical airway if need be. Next slide, please. So when we think about the surgical airway, the quickest, easiest, and quite honestly, the most dangerous is the cricothyroidotomy. And this is where understanding where the vocal cords sit again. Remember, they're in the thyroid cartilage. So the first bone that you feel up there is the hyoid bone, and then you feel the thyroid cartilage, and then you feel your cricoid cartilage. That if the cricothyroidotomy is somebody has a lot of times you see it in trauma, full of blood. You can't establish an airway. They're in distress. Their SATs are dropping. It's a chaotic situation, and you just need to establish an airway. So you poke a hole into the neck, trying to feel your landmarks between the cricoid and thyroid, and kind of stab all the way down in there, and just even like a pen or a small ET tube, something to get in there to establish that airway. Anything to get in there to establish that airway. The problems with this, oftentimes when we see them done in an emergent situation, they're always done in a chaotic situation. And sometimes they get placed too high, into the hyoid, between the hyoid and the thyroid, rather than the thyroid and the cricoid. So then it's above the vocal cord. So you're not getting really good ventilation and oxygenation to those patients. So they might not reverse, even though you've established what you thought was a surgical airway. The cricothyroidotomies, when they're done, they need to be immediately, once the patient stabilized, converted into a tracheotomy. There again, yeah, it's a surgical airway. Yeah, it's an option, but it is not a good option for many, unless need be, because oxygen is still important and establishing an airway is still important. So you need to know about it. Next slide, please. So then there's the tracheotomy. And so hopefully we can do these in a controlled fashion, but a lot of times, and you can see this is a patient that I saw probably about 10 years ago that had a self-inflicted gunshot wound by accident, where it took out his mandible, jaw, so he had a bunch of bleeding and all that, but it came into the emergency room, and we were able to actually establish an airway on him, and then do surgeries on him and give him a tracheotomy in a controlled setting. So that was really good. So we try to do it in a controlled setting as much as we possibly can. And that setting is typically in the operating room. I think you guys have been around when I've had to do a trach up on the floor, and some of my colleagues have had to do a trach up on the floor. That is not the ideal situation. The ideal situation is that we do them in the operating room in a controlled setting. Can we get the patient intubated first with the breathing tube, breathing for them, oxygenating for them, ventilating for them, and then do the tracheotomy once we have their airway established and secured. So sometimes we have to do that prophylactically, meaning that we anticipate the need that the patient is not going to do well from the tracheotomy standpoint, and we need to put the trach in just as a precautionary. And sometimes we have to do it because they need to have an airway, and either they have a dysfunctional larynx because they've had chemoradiation therapy, or they've had an obstructing lung cancer, or obstructing head and neck cancer, that they can't breathe by, and we got to bypass the tumor, and we got to bypass the upper aerodigestive tract, and so we put a tracheotomy in. So the key thing is it's a tracheotomy. So an otomy means a hole in that organ. So it's a hole in the trachea. It's not an ectomy where you remove the trachea, or a laryngectomy where you remove the larynx. It's a tracheotomy. And so the anatomy is intact above your trach. You put a hole in the trach. We always try to put it about 2 cartilaginous rings below the cricoid cartilage. So we feel where the cricoid is. We put a hook in that cricoid cartilage. We pull the trachea up into our surgical wound, and then we try to go 2 rings below the cricoid cartilage. Sometimes we want to go higher, like if they're going to need a laryngectomy. Sometimes we have to go lower if there's a tumor that has subglottic extension. But that's the idea, is you put a hole in the trachea. And some of the things that you guys might see that we do differently, some of us just put a hole in the trachea and put a tube in there. Some of us put a hole in the trachea and would do what's called a window, where they put will cut the anterior tracheal ring and make a little flap, and they'll put stitches out so that if the tube falls out, all you have to do is pull up those stitches, and then go ahead and the idea is that you can pull the trachea up to the surgical wound and re-intubate that trachea a lot easier. But for the most part, after about 3 days, that tract between the skin and the trachea is matured enough that you could take the tube in and out. But ultimately, since it's a tracheotomy, that if you leave that tube out, it will eventually heal over on itself. Next paragraph, please. Or next slide, please. Versus the surgical area, we have a laryngectomy. And so this is a patient here. This is with a mandible filleted open. He's got his maxilla there. He's got his posterior pharyngeal wall and the soft palate. You can see his uvula there, but his voice box is gone. His larynx is gone. And then, so what we need to do is we have to reestablish his digestive tract by closing his pharynx. And we need to attach his trachea to the skin here by actually formalizing a tracheostoma. So why I chose this picture, because nothing shows it better than there is nothing above the trachea here, right? The anatomy is gone. So there is, and I've had a patient die in an outpatient setting where she was struggling to breathe, and the paramedics were called, and the paramedics were coming to try to intubate her, and her husband kept on saying, she's a neck breather, she's a neck breather, she can't be intubated, and she ended up dying because of that. And I think she would have probably died anyways, but you know, that this was a complete not understanding of what her anatomy was, that all they had to do was put the tube right here. And actually, it's impossible to, ventilate somebody with a laryngectomy if you're going to try to intubate them through the mouth. It's just not anatomically possible. You got to put it in the tracheostoma. Versus a tracheotomy, if the tube falls out and they're developing respiratory distress and you can't get the track again, you could be able to intubate them from above, obviously, depending on what the underlying cause of that tracheotomy was. But that's the big difference between a laryngectomy and a tracheotomy, is what do we do in a situation? Can I intubate the patient from above? And the answer is absolutely not in a laryngectomy. So why do we do laryngectomies? We do them because there's cancer there. We do them because they develop a dysfunctional larynx. So the larynx has 3 functions: swallowing, speaking, and breathing. After chemoradiation therapy for laryngeal tumors, they might have the anatomy of the larynx preserved, but the function of that is not preserved. And so it becomes a dysfunctional larynx. So they become either trach dependent or feeding tube dependent, sometimes both. And then they require laryngectomy. There is a other entity that I just kind of want to introduce to you. It's called a tracheolaryngeal separation, where you actually separate the trachea and the larynx in a setting of aspiration. So this was a lot of times done on patients who have feeding tubes and they're trach dependent, and they continue to aspirate. And so it's trying to completely separate their digestive tract from their respiratory tract, and with the idea of reversing them. Now, I've never done one as a staff. I've done them as when I was in training, and never did we ever reverse any of those patients. But you just need to know that if you ever hear of the Lindemann procedure, or the tracheal laryngeal separation, that's why we do it for chronic aspiration. And there again, if the patient's going to have a tracheotomy, it's separated at the level, so your trachea is separate. So they got a permanent tracheostoma, and you kind of basically have a closed pouch here of the trachea on the other side. So you cannot intubate those patients from above. And so you have a creation of a tracheostoma. Next slide, please. What I wanted to show you here with Tara is she's actually a pretty remarkable person. Tara is. I had to take her voice box 6 weeks before her wedding for adenoid cystic carcinoma, so a cancer of the minor salivary glands above her at the level of her trachea. So she needed a laryngectomy, and then she had to go through radiation therapy. And what she's doing right here is showing you esophageal speech. So I don't know anything about technology, but if you guys could get the volume up on that, that'd be great. If not, then we can move on. But she taught herself this esophageal speech, and she speaks amazingly well. Like, you can't tell, like she can carry on a conversation without any problem whatsoever. It's quite remarkable, pretty amazing on how she does that.
Go ahead.
All right, my name's Tara Huberty. I'm 24. August of 2015, I was diagnosed with adenoid cystic carcinoma. September 3rd, they removed the tumor through surgery. On October 10th, I got married. I had a total laryngectomy, so I did sign language for my vows. And then I started radiation that week after my wedding. Now I'm a year out, and I'm pregnant with twins. What else should I say?
That's good. And you got you're working, great
Right.
voice.
And I taught myself how to talk. I'm working full time.
Yeah. This is esophageal speech, and she taught this technique to herself, and she does excellent with it. Oh, thank you very much.
So you can see that she has a tube in her trachea. Not everybody with a laryngectomy needs to wear a tube. But she does have that tube in there. And then that filter you see on top is called an HME filter. So it kind of replaces the nose. It kind of makes it a less turbulent flow, heats up the air, moistens the air, and filters out from any other, the stuff that the nose would normally filter out. So that's what that's esophageal speech. And compare that to this next gentleman here.
So, 5 years old. I have 4 children, 2 boys, 2 girls, and I have a wife. Been married 26 years. On the 17th of August this month.
All right, and why don't you go ahead and remove that now, and then tell us what has happened to you since May.
May 17th, I got a laryngectomy, and I have learned to talk with the electrolarynx. And last week, I got my TEP, and everything's going real well. And I'm learning to speak with this now. So I have 2 forms of speech: electrolarynx and the TEP.
That's perfect. Thank you.
Mm-hmm.
And you can see what he's doing is he's pushing on that filter where he has that tube, and there's a prosthesis that is a communication between the a one-way valve between the trachea and the esophagus that he pushes on that to kind of allow that air to vibrate to give him his voice. So basically, what I think is the most important takeaway is understanding the differences between the trachea, a tracheotomy, and a laryngectomy. The laryngectomy, the trachea is a direct communication to the tracheostoma here. With a tracheotomy, it's not that, you can still intubate a patient from above. When you have a tracheotomy, when you have a laryngectomy, you cannot. On that note, I am done. So if there's any questions for me, feel free to ask them. So
Dr. Lynn.
yeah, I see a question there. Is there a reason why sometimes you see a trach tube in a laryngectomy rather than a Lary tube? Which makes it even more confusing sometimes, right? So yeah, if we're worried about the secretions in the fluid, let's say like from a flap going down, or then we would want to put in a trach tube to kind of put the balloon up, so to kind of prevent all the secretions and everything going down into the airway. That'd be one reason. Sometimes they're so deep down while they're the healing process. So the stoma is so deep because we have a flap in there, and we only had a short amount of trachea that we use. We put a trach tube in there just because it's longer than the laryngectomy tube. Sometimes they're stiffer, and so if they have problems with stenosis of their tracheostoma, putting a stiffer tube in there can help as well. Any other questions?
No questions from the room, Dr. Lindau.
Well, thank you very much for your time.
Thank you.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.